Good morning, everyone. Thanks for attending this morning. Got a nice action-packed program for you this morning. So just a little bit about myself. My name is Andreas Klie. I'm an RDT in Canada. Celebrated my 40 years in dental technology last year, so it was a very big benchmark for me. But I'm really happy to be here today and to present to you. I don't know, for those of you that don't know, we now have a collaboration with Ivoclar. So a really exciting time for all of us. And what I'm going to show you today is going to be a little bit of a workflow, not so much in a product, but how we took a patient from beginning to end with a great solution. So without further ado, a little bit about Panthera. We're a company in Quebec City in Canada. We're a patient-centric company. What does that mean? We look for solutions for patients. Yes, we're selling a product, but at the end of the day, we're trying to find solutions for sometimes very, very difficult situations for patients. What are some of the challenges that we face in the dental industry? Most times, it's space. How much VDO do we have? So we're always challenged about how much space do we have for a prosthetic restoration, be it a crown or a full arch restoration. Second of all, if it's an implant retained case, what are the implant placements like? Are they placed anteriorly, very little AP spread? Or do we have very divergent implants where aesthetic becomes an issue? That means we have to then look at what type of restoration do we do? Do we do a fixed restoration, removable restoration? So at the end of the day, it's not just about selling a product to a patient. It's about finding a solution for a specific issue that we're trying to address for that patient, right? So what I'm going to do today, this is a roadmap of a specific case that we did with a denturist in Ontario last year. We're going to go through the whole roadmap and see where we started and where we ended up for this patient. I think the end result was great, but I'd like to take you through this route of where we went. So we started off with treatment planning. And at this point, we had to find options, and we also had problems. So we had to see what the problems were, what the options were, and at the end of the day, by consulting both with the patient and the doctor, we came up with a solution. And this is the solution I'm going to run through with you today in this presentation. So we started off with a surgical intervention. I'm going to talk a little bit about the patient, how the patient presented herself, what we did for the patient to make her the best restoration we could for her case. We did the case preparation. This, at this point, is what are we going to present the patient with, right? What are her options? She obviously has the final say. She has to make a decision what she wants as a restoration. I'm going to talk a little bit about the impression techniques that were available. I don't know how many of you here are doing digital, analog workflows. I'm going to go through a little bit of all of them. So we're going to go through the impression techniques, different type of scanning technologies that are available to you, and then the lab phase. So this is the phase where the case is planned. This is the phase where you will present everything to Panthera to do the final restoration for you. The prosthetic design, this is going to determine what the end result is for your patient. And this is the lab phase. How many of you here are technicians? How many of you are dentists? No dentists? So all technicians, pretty much? Okay. So a lot of it in here. I know there's one clinician here. But it's going to be a lot of what you need to do as a lab technician to get the right product to us, to give you the right end result for the patient. We're going to talk about the bar design, because at this case, we actually ended up doing an implant bar for this patient, right? We looked at different options. The patient went one way. The clinician went another way, but at the end of the day, it was really the patient's choice. So we're going to look at the bar design. We're going to look at how the bar was produced, how the final restoration was produced. And then finally, we're going to look at the case delivery for this patient. And I can tell you the outcome. The patient was really happy, but we're going to go through each of these steps individually. So the case delivery at the end for the patient. So a little bit about the patient and the clinical study. So this was really a multidisciplinary approach. It was not just the clinician. It was not just the technician. It was not just us from Panthera. It was a multidisciplinary approach that we used to give us really, at the end of the day, the best result, right, for this patient. So a little bit about the clinician. The clinician is Andre Coman, a friend of mine. He's in Ontario, is a denturist, a very, very talented denturist, and he has a Smile Care Denture Center. It's a very high-tech denture center. He went from being full analog, he's now full digital. So everything in his case was done in a digital realm. A little bit about the patient. The patient was a member of parliament in the riding, 73-year-old Virginia B, and she presented herself when Andre and I were sitting down one day, and she had a very definitive thing in mind that she wanted to have done. But at the end of the day, she relied on both Andre and myself to come up with the best solution for her. So we did a full upper, and we did a partial lower for her. The key findings were, on the lower arch, there was a lot of pocketing in the teeth, but it was not so bad that we couldn't do at least a partial for her on the lower. The problem really was that the upper was extremely periodontically compromised. So there was really not much to do for her on the upper anymore with what she had. So the primary concern, she had a lot of discomfort. Her uppers were mobile, so she had a lot of discomfort. She couldn't chew properly anymore. So a decision had to be made for her at this point. So her expectations were she was going to have an upper denture. But the way that she presented, this was not a great option for her. So if we start the journey, we started with the treatment planning. So in her mind, she wanted something that was fixed, right? So we gave her the two options. What were her two options? The two options were a removable or a fixed. Her choice, she said, you know what? I'm going to have implants done. And if I'm going to have implants done, I do not want something that I can remove. I want to have a fixed restoration. I'm paying all this money. I want to have real teeth. So at the end of the day, we gave her the two options. We gave her the removable option, and then we gave her the fixed option. But the removable option at this point was not for her. She did not want that. So the second option was a fixed. And this is really where she wanted to go. She wanted a fixed restoration. We could do a fixed hybrid acrylic wraparound. How many of you do fixed hybrids? Acrylic wraparounds? Any of you? We'll talk a little bit about that. The second option was zirconia, right? That was really, at this point, this is the way she wanted to go. Initially, she wanted to go with the acrylic wraparound. Aesthetically, great. The problem is, as we all know, hygiene was an issue. So her choice was the full zirconia. What were the other options? We don't know. Because at this point, she'd already made up her mind. She had decided that she wanted to do a zirconia as a restoration. So if we go back and we explained this to her, we said, look, you can do acrylic hybrid wraparound. However, it's the all-on-4 concept. It's a very known concept. It's great. It's a fixed restoration is exactly what you wanted. It is great aesthetics. It was acrylic, and as we know, acrylic is not the most hygienic material to have in the mouth as a fixed restoration. So difficult to keep clean for her, and poor hygiene. So for somebody who's lost their teeth, we've put implants in now. The last thing you want to do is put something in her mouth that's not hygienic. Those implants are eventually, you're going to get peri-implantitis, and you're going to lose those implants. So this was not really an option for her. So the problem, and this is the pain point for many clinicians, when they do these acrylic hybrid wraparounds, what are these pain points? So for those of you that have done them, there are very, very distinct issues that we have with hybrid acrylic wraparounds. And the biggest problem we have is hygiene and breakages. Imagine it's an acrylic. It's screwed down into the patient's mouth. if it's badly designed, you have no way of cleaning it properly. So at the end of the day, you're going to end up with breakages, you're going to end up with inflammations, and as a result, you're going to end up with something like this, right? Not where you want to be for a patient. This is a combination of not only because it's acrylic, but also bad design. So remember, guys, when you do something that's fixed in the patient's mouth, it needs to be ovoid, no ridge lap, right? Anything that's ridge lap, the patient cannot clean underneath. And this goes not just for acrylic, for any fixed restoration. Make sure that it's ovoid. Yes, you're right. It's got to be, right? So when you have your tissue contact, they have to be able to clean underneath. So this is how it would present itself if we didn't design it properly. So where did we go from acrylic? The market started embracing zirconia. You're in the Ivor Club ballroom today, and as you've seen, there are great zirconia products. So what did we achieve with zirconia? We were able to increase the hygiene because of the nature of the material. We were able to give better tissue reaction because it was not acrylic on the tissue, it was zirconia. So the tissue reaction was a lot better. And of course, a very big point is we managed to increase strength, which, remember, in a hybrid acrylic wraparound, strength and breakages was a big concern for a lot of patients. However, even though we thought we had the right solution, we still had issues with zirconia. And it's a pain point for many clinicians as well. Not as many as we had with acrylic, but there are pain points for zirconia as well. Breakages. This is a real fact, right? These are the type of situations that we see with zirconia. Unsupported zirconia, breakages. And if you notice where these breakages occur, they're all in the tie base area where we place the tie bases to screw down the restoration. So thickness of the zirconia. To screw down a zirconia, we need to use tie bases. This becomes a weak point in your restoration. And most of the breakages in zirconia occur in those places. So the second point is cantilevers. As you may or may not know, with zirconia, you are limited how far you can go back in a cantilever. So if you have a very small AP spread, you're not able to go very far back. So, example, a patient's got 4 implants. The AP spread is very small. What do? We're only able to give them maybe half an arch of teeth. This is not what they paid for. They want to have a full arch of teeth, right? They want to have a full set of teeth. So the cantilevers unsupported were another issue for us when we started looking at breakages in zirconia. So we had these issues in acrylic, hybrid wraparound, in zirconia, and we had to come up with a solution because this is not the way we wanted to go. So we had the problems, and then we had a solution. And this is what I'm going to introduce you to today, is the Panthera Fusion Bar. Okay, you're nodding your head. You know it?
No, I want to know about it.
You want to know about it? Okay. Okay, good. So this is where we're going to concentrate on today because this is really the route that we took with Virginia. Right? We presented this to her, and when she saw it, she said, that's it. That's what I want. This is the solution I want in my mouth. Right? So what are we trying to achieve with the Fusion Bar? I think the pictures are self-explanatory. Right? So what is it? It's a titanium bar that supports the zirconia. There are 2 issues here. If I screw zirconia directly onto an implant, it's on tie bases. The tie bases are cemented into the zirconia. What is the weakest point of that restoration? The cement, exactly. So the cement is not really the glue that's going to hold everything together, right? It's going to go. If the tie base is not secured or placed properly, it could lead to impassivity. So what happens if I tighten down a zirconia restoration that's not passive? It's going to break. A microfracture is going to take place, and at some point, it's going to break. So we needed to find a solution where we can eliminate the tie bases. So we have a solution where we have a titanium bar. It increases the overall rigidity. If the impassivity is there in that bar, it's going to be in the bar, not in the zirconia, right? So we did some internal tests at Panthera, and we found that the zirconia supported is 30% stronger than unsupported. So we've increased the strength of the restoration. Offers proper support for extended cantilevers. Remember I said we want to be able to give the patient a full arch of teeth. So we're extending the cantilever range for the patients. And this is very important because remember I said right in the beginning, what are the biggest challenges we have? Space is always an issue for us. As a technician, I can tell you it's so frustrating when a doctor asks you for a certain restoration and you tell the doctor, sorry, I don't have enough space for that. Yes, but I want that type of restoration. Now we have a solution where you can address this issue. So low profile, and most importantly, the intaglio is highly polished. So from a hygiene perspective, the best restoration you can give this patient. So which type of patients are going to benefit from this type of restoration? They are the patients that want a high-end aesthetic restoration with the most natural look. You've seen all the products out at Ivoclar now. They're prime discs, they're new ceramide. I mean, you can really give them a really, really high-end restoration without the worry of something that you do for them is going to break at the end of the day. We want to restore stability, function, and the feeling of natural teeth. Acrylic is not a natural feeling in the patient's mouth. Zirconia is more closer to the natural dentition. So we're trying to restore a more natural type of restoration for the patient. Enhanced strength of the prosthesis, the combination of the titanium bar and the zirconia has now enhanced the strength. And of course, we're going to extend the range of the cantilever. The cantilever now allows us to go further back. Right. Next in our pathway, we are going to go to the surgical intervention. So what did we do for Virginia B? We had to do some extractions. So the first was to extract all the remaining upper teeth. Right? They were mobile. There was nothing we could do with those. And when I say we, not me, but the clinician in combination with our consultation with the patient. Originally, we were going to do 6 implants, and the surgeon decided 7. One of them was laid dormant. They didn't need it, but they wanted it there just in case. So it was over-planned, but I think better that than under-planned. So 7 implants were placed, and then there was a temporary provisional done to make sure that everything was good, check the fit, the function, make sure everything was done, that the patient was comfortable, and then we could get the right aesthetic. And at the end of the day, whatever the patient was happy with is that restoration, that temp, is what we were going to use for our final prosthesis for the patient. So at this point now, the case preparation. We've done the surgical intervention, the implants have been placed, and the temp has been done, the occlusion's been determined, aesthetics has been determined. Now we do the case preparation. So we started looking at impression techniques. Now, as I said to you earlier in the presentation, Andre Coleman has gone full digital. So these are your options for impression taking, right? The first one, I'm sure we're all familiar with the conventional impression technique, right? What is the problem with that? We're working with different materials. We're working with stone, with impression materials. So dimensional instabilities is a big thing. Material shrinkage, the stone, the impression material. Laboratory inaccuracies, no matter how good we are as technicians, I've seen it, I've been there. We mix, we don't follow instructions properly. The stone expands too much, not enough. So there are laboratory inaccuracies, and it's a time-consuming procedure. You have to take an impression. You have to put impression copings in. You have to pour up a model. You have to do a soft tissue. It's a long, tedious process, right? So we have another option. We have an intraoral digital impression. I'm sure all of you have heard this whole thing about photogrammetry. Am I right? It's the hype of today, digital impressions. But I can tell you, this is where the industry is going. It's in intraoral digital techniques. And then we have the extraoral digital techniques. So now it's not only just one system, we have two. The one is a grammetry system, the other one is a photogrammetry system. So we have these two techniques, and in this case, for Virginia, it was decided to go with the intraoral, only because this was the system that was available to the denturist. So just a little bit about stereophotogrammetry. So what is nice at Panthera, we are compatible with all of them. We started off small, but at this point now, no matter which system you use, we are compatible and we're able to work with that type of system. So the first one on the market ever, this was around about 2010, was the PIC system. It was the most, and still is today, the most accurate photogrammetry system on the market. The problem is with all of these photogrammetry systems, they are extremely expensive, and they only capture implant positions. They do not capture any soft tissue. So what does that mean? If I take a photogrammetry scan, I have to do one for the implant positioning, and then I have to do a second one where I now do a scan of the soft tissue, which means I need two pieces of equipment. So it becomes a really expensive way of taking impressions. So the PIC, the iCam today for us, I'm from Canada. In Canada, iCam is probably the most popular one right now. But it's an expensive piece of equipment, and it only picks up the implant position files. And then the last one is Micron Mapper. So no matter what type of system that your customer is using, please know that at Panthera we are able to accommodate all of these type of systems. However, there is a second option, and this is the most popular option right now in the market, is the grammetry. So I'm sure, maybe not, but these are the most popular ones that we come across, is the IO Connect system, and then we have the Shining 3D. And this case that I'm talking about today was done with the Shining 3D scanner and flags. So just to show you, in the grammetry and photogrammetry realm, 50 microns is accepted as accurate. And all of the photogrammetry systems fall well within that. Even the grammetries fall under the 50 microns. So it's a lot more accurate than it is in an analog form. So if we look at the scanning process that took place, so a comprehensive scan was performed for anatomical landmarks, which including, we have to get the palate, we have to scan the residual ridge. Why is that important? This is the seating surface of the restoration at the end of the day. The implant positioning, of course, the most important. Without that, we have no basis. So we need the implant positioning, and the opposing arch was scanned to make sure that our bite and our occlusion is in place. So just a bit of about the scanning. When the patient is scanned, they have to be smooth, steady scans and focus on and interact directly with the prosthesis. So what is that? It's the soft tissue. It's the ridge, right? And what's also very important is when you use one of these scanners, the grammetry scanners, intraoral scanners, what happens a lot of times is they scan randomly. The problem is the information is taken in, and the scanner at some point cannot read it anymore. So what is important when you're scanning is to make sure that you have a proper path of scanning. Normally, it starts in the posterior on one end until you get to the anterior, and then you go back and forth to get your incisal, your labial, and your lingual, and then you move over to the other arch. Then you go the whole buccal and the whole lingual side. And if you do this and you get a proper scan path, your information is condensed, because if you don't do that and you go back and forth, the scanner is going to try and stitch all these pieces together, and you're not going to end up with a great accurate solution. So the scan path, very, very important. Right, so when we did the scan, so this is the grammetry of shining. This is what we used for Virginia. So proper seating of the scan bodies. This is crucial. A lot of times, scan bodies are put in, hand tightened, great, let's go. The problem is, if there's any tissue impeding the scan body is going to sit high. That's not going to be accurate enough. So we have to make sure they are seated properly. What's the best way to make sure scan bodies are seated? Anybody? X-rays? Right. Now, a lot of times this is not done. So we rely on the clinician to make sure that the scan bodies are seated properly. So very, very important. This is the base of everything. That is the difference between an analog workflow and a digital workflow. In an analog, I have a model to check something on. In a digital realm, I have nothing to check it on. So I really rely on the clinician to make sure they've done their due diligence and they've actually made sure that those scan flags are seated properly. Second one, the way that the system works, you'll see little dots on the horizontal scan flags. This is only for implant positioning. It does not encompass any soft tissue. So what happens is when you scan this, it stitches all these little markers together, and once they've all correlated, they're going to give you the implant positioning. That's one step of it. At that stage, these are removed, and we put in what's called healing caps or healing posts, scan posts. They're little horizontal posts. Now you scan, as I showed you in the slide before, with that definite path of scanning. Now you're scanning your soft tissue, right? And that's the important part. So all scan bodies and soft tissue areas around them are scanned. So at this point, we've done our scan flags, our implant positioning, and now we've done our soft tissue as well. Bite registration, a temporary was placed. We checked the bite. We made sure that everything was in place, because at this stage, whatever temporary the patient is wearing is what's going to be the final product. We're going to take that temporary and convert it into the final product for the patient. Patient asked to bite. We took them into centric. We did some excursions, made sure that everything, the excursions, canine guidance, everything was good. And at the end of it, the scan is used to capture the buccal surface and both arches. So now we have everything complete. We have the upper that we are going to do the restoration on, but we also have the bite, and we have them in relation to each other. Okay, and we move on in our path. So where do we go now? This is where you guys come in as technicians, right? This is the lab phase of everything. This is where the magic happens. Remember I said we have the different scans. We have a tissue scan. We have a temp scan. And we also have the implant position, tissue scan, and the actual prosthesis. At this stage in your lab, what you would do is you would stitch everything together, either in ExoCAD or 3Shape, depending on what system you're using. Stitch everything together. So in the lab phase, you'll notice in this original scan, there were those horizontal scan flags. You in the lab at this point are going to convert this into a scan body, a workable scan body for the lab, which in this case is a DES scan body. So scans are used in the final. So you're going to take the information the dentist has sent you and convert everything into a workable scan body. For our case at Panthera, we are compatible with DES. So DES is the way that we need it. And using the temporary as a guide allowed us to preserve the aesthetics and function of the prosthesis and improve tissue adaptation and compression. Now, what is important is tissue compression is always a sore topic, because we never know, do we have too much tissue compression, not enough tissue compression? And what I really like the way Andre approaches this is he does 3 temporaries, one with very light tissue compression, one with a medium tissue compression, and one with heavy. And what he'll do is he'll start with the light, check for blanching, make sure that it's seated properly, that the patient's able to clean properly underneath, and then he'll place the heaviest one. If there is a lot of blanching and the circulation stopped, it's too heavy. So, but having these 3 different restorations allows him to really hone in on the best tissue compression for this patient. So there were 3 provisionals done. and finally narrowed it down to 1, and this is the one that we then worked from. What that allowed us to do is give him the perfect restoration at the end of the day. Right, so what do we at Panthera need to fabricate this fusion bar? We need not this, and this is what we get a lot of times, because the final restoration that we give you is really a replica of your prosthesis or your temporary that is in the patient's mouth. So over here, you'll see we have a denture with flanges, palate. This is not what we need. We need something that represents the final, right? The intaglio, as I said, the tissue compression is established. There's no flange. There's no palate. It is really the final restoration that's going to go in the patient's mouth, and that's what we need. That is exactly what we're going to work from. So, talking about intaglio surface, compression, this, remember I said right in the beginning about the all-on-4 and the inflammation that the patient presented? It's because the intaglio was not designed properly. We want something that's either flat or concave or convex, right? So this is an ideal situation. This is Virginia B's case, and slightly convex, right? We want the intaglio surface as flat or convex as possible. It's the easiest way for the patient to clean. Why? Well, convex minimizes soft tissue irritation, reduces the risk of food entrapment, and it promotes healthier tissue and provides a better seal. So when you design these type of cases, guys, please make sure that the intaglio is designed the right shape for better outcomes at the end of the day. So at Panthera, we have a few different types of workflows on how to get the fusion bar. So the most common one is the U-scan we design and mill. So it's a digital workflow, intraoral or model. So it's intraoral, photogrammetry, or an analog model. So what are the 4? We need 4 scans for a fusion bar. The first scan is a soft tissue scan. No scan bodies, nothing, just a soft tissue scan showing the soft tissue and the implants, but not the actual implant positions. It just represents what's in the patient's mouth. The second one is now our scan with a photogrammetry or intraoral, encompassing the scan bodies, whatever we're using, whether it's horizontal scan bodies or vertical scan bodies. The third one is our temporary or our prototype in the patient's mouth or on the model. And the fourth one is a 360 scan of the intaglio. Right? So we need, really, in essence, these are all the scans that we need. And we can go forward with the manufacture. I think we can all agree it's a pretty easy and simple workflow, right? So this is the case. Once we receive the scans, we have a software that we design everything. So with a fusion bar, what we do is we take your prototype and we split it. It's called file splitting. There are 2 components to this. The one is the bar, and the second part is the overlay, the zirconia, that's going to go over that bar. So those of you that have worked with Panthera may have seen this already, but this is a 3D viewer that we have available for the labs. And at any point, they can go in, they can rotate, they can check, they can take the denture off, they can put it back. So it really gives you full control of what you want in the design, right? So you can check how much space do you have, where are the screw access holes coming out, and you can, at the end of the day, either ask us to make changes or say, no, I really like this. Let's go ahead. Let's work with it as it is. So in this case, we did exactly the way he wanted. There were no changes to make, and we went ahead and went into production. And what's also great here, we have a 3D viewer. In the 3D viewer, you can do a cross-sectional cut. And I don't know if you can see it, but there are little blocks. Each block markates 1 millimeter. So if I look here, I can say, oh, I have 1, 2, 3, 4, 5 millimeters space for zirconia. Perfect, right? Sorry, bit of a sinus going on there. Okay, so anybody familiar with the fixed prosthetic classifications? Right? So what is great about the Fusion Bar is it really accommodates all the FP classifications. Fixed prosthetic 1, which really is just the teeth, no tissue. The FP2, which is teeth, interproximal tissue. And then the FP3, which is really, like we know, the all-on-4, it is flange and teeth, right? Initially, when we started with this project, we only had the FP3. At this point now, we are compatible with all of them. So no matter whether your patient presents as an FP1, FP2, or FP3, it's possible. Let's look a little bit about the difference. So what is the benefit of the Fusion Bar? What are the characteristics of the Fusion Bar? And as technicians, I think you'll all understand this, is low profile. Remember, I said in the beginning, what is our biggest challenge? It's always space. I never have enough space. What is great about this type of bar is that I can go down as little as 5 millimeters, which in any restoration is almost unheard of. Right? If I had to do a full zirconia bridge with only 5 millimeters, there is no way that zirconia bridge is going to last. So little or no bone reduction is required. And in FP1, there is no bone reduction required at all. So once you do bone reduction, it's done. There's no going back. So if I can prevent or not have to do bone reduction, great. So this will award me that type of situation. You'll also notice there are all rounded edges. 2 reasons. If I have a sharp edge and there's an occlusal force on that sharp edge, what's going to happen? It's going to fracture, right? Sharp edges causes fracture. Rounded edges prevent fractures. There's no fracture points. Number one. Secondly, when I mill a restoration internally, what is the shape of my burr? It's not square, it's round. So for me to mill an internal geometry that is square with a round burr, it's difficult. So we've actually facilitated and helped the labs to mill the restorations by making everything round. It's easier for them to mill. The burrs also have a certain diameter, so we need to make sure that when they mill the restoration, they're able to accommodate the space for the burr. So everything is taken into consideration in the design of the bars. We have a 10-degree chamfer on the labial, on the FP2, or FP3, and a labial and lingual on the FP1. Now, the 10-degree chamfer, how many of you are familiar with telescopic crowns? Right? What do they rely on? A seating with pure intimacy, right? So with a 10-degree chamfer, what I'm creating is when I place my overlay onto the bar, it goes down until it gets to the 10-degree chamfer, and then it slides into position and it locks it in. There is no more lateral movement. It guides it, keeps it in that position, and it's stable, right? So it also ensures a perfect seating position. So in the 10-degree chamfer area, there is no cement gap. So your cement gap is only from the 10-degree start of the chamfer to the other side. That is your cement gap. The rest has no cement gap. It's an intimate fit, means no lateral movement. We have a 90-degree seating in the FP3. It just prevents any horizontal fractures. It's a stop. When the patient bites down, it prevents any breakages. And we have a constant cement gap. And this is very important as technicians. It is determined on the bar, not the overlay. Why is that important? When I mill the bar, at this point, I'm going to control the cement gap, and the overlay that you are going to get, that you are going to mill in your lab, for example, you don't have to do anything. You receive the STL file of that overlay from us, and you put it in your position and in your nesting software, and it goes straight to the mill. You do not have to think about cement gaps or anything else, it's already done by us in the bar. And one of the features that's really neat is an angulated screw channel. So if I do have a situation where I need to correct some angulation because the implants are not placed aesthetically, there's an aesthetic compromise, we can do angulated screw channels. What is great about the way we do the angulated screw channels, we use the original manufacturer screws, not aftermarket screws like all the other angulated screw channels. So if it's a Nobel, a Straumann, a Zimmer, we use the original seating geometry of those manufacturer screws. Okay, why the 10-degree chamfer? So it's self-positioning. When I put that overlay onto the bar, it guides it into place and it's positioned properly. Guarantees a perfect seating position, and I said that there's no cement gap in that area, so it creates an intimate seal for hygiene. So if I look in this area over here, how many of you went to Hugo Hubert's presentation yesterday? So this is his case that he did. So, but you can see what this does. It brings the transition line really high up. So if you have a patient with a high smile line, they're not going to see that transition. So the Panthera design, as I already showed you, it's a lingual seating and a 10-degree chamfer in the labial. Our competitors have different designs. They have different philosophies, right or wrong. But the problem in this situation, here's my cement gap. Here's my cement gap. But look at this. Here's my stop and my guide. There is no more possibility for this restoration to move laterally. In this one, here's my cement gap. I have a possibility of micro movement. What does that mean? If I've already dialed in my occlusion, everything is perfect. Now I go to cement the two together, and if there's a slight movement, what's going to be off? My bite. So I've done all this work, and at the end of the day, the bite's off. Why? Because I didn't have that proper positioning guide. So the benefit with a 10-degree chamfer is really proper positioning. The 90-degree seating, it creates a perfect seating position, provides vertical stability. As the patient bites down, creates perfect stability for occlusion. The cement gap, as I'd already mentioned, cement gap is 100 micron, but it's only up to the 10-degree chamfer, in both of these. And it's on the bar, not on the overlay. Right. So are we talking only about full arch cases? No. We can do bridges, short span bridges, 3-unit bridges, 4-unit bridges, any type of restoration where we want to support the zirconia to prevent breakages. Even in short span bridges, if I have a 4-unit bridge, there's a chance it could break. So why not put a bar underneath that bridge just to support it? Yes, I have a question over there. It's only over implants. Yeah. I had a question yesterday. Someone asked. If you go to our website or you call our support, they may be able to help you. There is a possibility that we could do it over preps as well. But yes, the question came up at our booth yesterday. At this point, we're only doing it on implants, but there have been a few questions about that. So not to say we won't, we could. Okay, so back to the bridges. So it's not only full arch cases, we could do it on bridges as well, on short spans as well. So this just shows you the difference between the two types of implant bars. The one is the FP bridge profile, as we call it, but you can see the 10-degree chamfer, labial, and lingual, and it's a very small, narrow restoration. And then the FP bridge, the FP profile, a bit wider. We're accommodating the FP3 design. In 2024, we won the Journal of Dental Technology Wow Product of the Year. So of all the products that were introduced in 2024, we won the wow factor for that year. So just a little bit of a distinction between the two types of bars. So FP1, FP2, you can see the design. So look at the space requirements for both of these bars. Very, very low profile. FP1, FP2, 5 to 8 millimeter. FP2, FP3, 8 millimeters in height. So from a bar perspective, it's a very, very low profile bar. The FP bridge, 2 to 3 unit bridges to full arch. The PFB profile is better for full arch restoration, right? So if I'm going to do a full arch restoration, yes, I can do it as an FP1 design as well, but better indicated in a Fusion Bar profile. Why? Because I have the 90-degree seating for better stability. In the FP bridge, I have a buckle lingual 10-degree chamfer, and in the Fusion Bar profile, I have the 10-degree chamfer in the labial and a 90-degree chamfer in the lingual. So this is just a comparison to differentiate the two types of bars. Not to say you cannot do any of your restorations with either or. There is no hardcore rule to say you have to do an FP bridge or an FP profile. Right, and this is the exciting part. Where are we today? We're at Ivoclar, right? So what we've done in our collaboration with Ivoclar, we've come up with a really, really nice workflow that makes everything so much more simple. So this is how the whole thing works. Panthera splits and creates a design in the trine and sends the STL of the overlay. While we mill the bar, so if we look at it, you start the case, you send your setup and your scans, as I'd already said in the previous slides, and you send it to Panthera. We split the bar, and we send the design to the customer, or we will mill it ourselves, depending on which way you want to go with this. Either you want to mill it yourself, or we mill it for you. Or we send you the file, and you mill it in-house, do the characterization. And the beauty of this is, while we're milling the bar, you're already working on the zirconia. So you're not losing any time. And when we finish the bar and we send you the bar, your restoration in zirconia is already done. So what's left for you to do at the end? To cement the two. It's an easy, easy workflow. So here's a comparison. So we have two different types. We have the bar and overlay STL. What is that? What is that? So we split the bar, and we send you, the lab, the STL file, as I just mentioned. So you will receive the file, and you characterize, or you mill it in your product of choice. You can mill it in PMMA. You can do a milled denture. You can mill it in whatever you like, Rodin, nanoceramic, it doesn't matter, zirconia. The STL file is your file for that case. So the material choice is really irrelevant. Of course, we'd like you to use the prime from Ivoclar, but it doesn't mean you have to. The choice is yours, right? The second option is Panthera splits and creates the bar, design in the overlay, and we mill the zirconia overlay. Now, we are using the prime from Ivoclar, just so that you're aware. So when you order a bar and the zirconia from us, it's going to be with the zirconia from Ivoclar. And then at the end of the day, you receive the bar and you cement it and cut with the characterized overlay. Or if we've milled the zirconia for you, you will receive the zirconia and the bar. You characterize the zirconia, and then you cement the two together. Now, how many of you guys have your own mills? You do. So I'm going to say the better option for you is to do the split file. We send you the STL, and then you work on yours. The STL file for these cases is normally sent out around about 48 hours after we split it. So think about that. In 48 hours, you're already working on your case, while we're doing what we do best, is mill the bar. And you do what you do best is your zirconia and your characterization. That's what you're all mastered at, right? So here's a breakdown of how it works. So you consult. We have the Ivoclar Smile Suite. Scan and design. So you scan, design in the ProScan 55, for example, lab scanner. Everything is sent to Panthera. Send the case to Panthera. Panthera will then split the file, and at this point, we send the STL file to you. You will mill with your PM7, whatever type of mill you have. You sinter it, characterize it, and then your cementation once you receive the bar from us. Right. How do I cement? I get this question all the time. What do I use to cement? How many of you cement tie bases? You've got experience in that, right? So the cementation process is no different, right? You have to make sure that you've sandblasted the surface, 50 micron. Make sure everything's clean, grease-free. My choice and the recommended is the multi-link. It is the nicest. It is the most accurate. It's also the most stable. We've had the best results with that. So you would use the Monobond Plus primer and then your multi-link hybrid abutment. And what happens, you get your bar back, and you'll notice there is a dark surface to the bar. You have two options. You can either order it as is, which would be a full titanium bar, or the choice that most people go with is we anodize the bar, and then we sandblast the bar first, then we anodize on top of that. So it already has the 50 micron sandblasted. So when you receive the bar from us, there's nothing for you to do other than clean it with alcohol, make sure that there's no grease on it, and then you cement the two together. And that's it. And there is your cemented restoration at the end of the day. So we've finally arrived at the final process, which is the case delivery. Virginia's been waiting 2 weeks for her case. She's finally going to get it. So this was the completed case. This was done with a prime disc. And this was the final restoration before insertion. What I'd like you to see in the little video clip, there was no occlusal adjustment made. It was screwed in. We checked the bite, and it was perfect. Right? All these features I explained to you about the 10-degree chamfer, perfect seating position, all of these factors contribute to the perfect bite at the end of the day. We checked it for optimal fit and function, so did lateral excursions. Everything was great. Everything was fine. Final insertion went very smoothly. Patient was extremely happy. She was expecting to have discomfort. She was expecting to have adjustments made. There was nothing. It was literally screwed in, and that was the end of it. So one of the safety features that we always recommend, when you do these big arch cases, please, guys, you know, they've paid a lot of money for these. Make night guards for them, right? Patient's Brux, it's zirconia. It can break, right? It can chip because night clenches are very common. Make them a night guard to protect whatever you've made for them. Right, so when we started this journey, it was a huge, windy road. It was a lot of factors, and it looked complicated. And it was so daunting. I'm never going to get this done. At the end of the day, if I summarize everything, it's really quite an easy path. It's simple, right? What did I do? I did my treatment planning. I did my surgical intervention. I did my case preparation. We went into the lab phase where we did the prosthetic design. We did the bar design. We did the production where we split the file. You got the STL. We did the bar. We cemented it. And at the end of the day, the case was delivered. So I took this long, windy, convoluted road, and it's really just come out to a straight, easy pathway to a final production. The patient was happy. Everyone was happy. The follow-up was done about 2 weeks after that. Patient had no complaints. And to this day, the restoration is still looking great, and everything was awesome. So, key findings. The scanning and the planning was very, very important. As I'd mentioned to you in the beginning, make sure that your tissue compression, everything is perfect. So everything you put in is what you're going to get out at the end of the day. So take the time to make and ensure predictable outcomes. The workflow, I'm sure we can all agree it's simple. It's easy for everybody to do. And it makes everybody's life as technicians easier at the end of the day. So in conclusion, we have an option that addresses aesthetics. Remember when we started? Aesthetics was a big thing. We have addressed strength. And for sure, we have addressed hygiene. I think we can all agree on that. And it gives full control of the workflow for your case. You have control of where you want to take this case. Either we mill the zirconia or you mill the zirconia, it doesn't matter. But you have full control of whatever you want to do. So, at the end of this, I'd like to thank you all, folks. It was a pleasure to be able to present to you. I hope I've given you some insight of what your options are, right? Just to let you know that the Ivoclar team will also be available. From now on, with the collaboration, they will have all our products, and you'll be able to talk to them as well. Recommend it to your friends. And guys, if you have any questions, please reach out to us. My email is over here if you want to take a picture of it and you have questions. Contact me at any time, please. I'm happy to answer questions, walk you through the process. And with that, thanks, guys. Appreciate your time.